Hello everyone, my name is IStine, and today I will be presenting my image evaluation for an AP pelvis radiograph. Throughout this comprehensive presentation, I'll be breaking down the positioning accuracy, the required anatomical structures, and conducting a highly critical analysis of the technical quality and degradation present in the specific exposure. Starting right off with our general image and demographic information, you'll immediately notice a glaring omission. Standard patient demographics are completely absent. But because we're evaluating a cropped textbook image, specifically image C7.82C from Bontrager's, we do not have the typical patient name, date of birth, date of examination, or facility ID. In a functional clinical setting, this lack of metadata is an immediate medicological failure and an automatic reject, as we cannot definitively tie this medical record to a specific patient. Compounding this meteorological issue, this is the complete absence of a physical anatomical marker. Scanning the entire collimated field, there is no lead R or L marker present to indicate the patient's right or left side. In a fast-paced clinical environment like an ER, rotation, failure to using a physical marker is a critical error. While digital annotation post-exposure is sometimes used as a crutch, relying on it introduces a high risk of lateralization errors and is generally unacceptable for legal documentation. On a positive note, there are no avoidable radiopaque artifacts such as zippers or buttons obscuring our areas of clinical interest. Moving on to our anatomical requirements. An optimal AP pelvis projection must demonstrate the entire pelvic girdle and proximal femurs. This image successfully captures all necessary structures superiorly. We have clear visualization of both left and right iliac wings, as well as the iliac crests. Moving medially and inferiorly, we can evaluate both the top left and right hip joints, including a clear margin of the acetabulum seated within the femoral heads. We can fully visualize the ischium, the pubis, and the symphysis pubis in the midline, the sacrum, and the coccyx, as well as the proximal aspect of the femurs. Looking at the lateral borders, we have clear evidence of collimation. The technologist successfully restricted the primary beam to the appropriate field size, effectively capturing the required anatomy from the level of the iliac crest at the superior margin down to the proximal femurs at the inferior margin, which is crucial for maintaining a layer principle and reducing scatter radiation. Now let's dive into the positioning accuracy. Starting with our central ray alignment, the central ray appears to be appropriately centered midway at the level of the ASIS, or the anterior superior iliac spines, and the symphysis pubis, ensuring beam divergence does not overly distort our superior or inferior structures. However, when we evaluate for rotation, there is definitive evidence that the patient was not positioned flat on the table. The primary indicator for pelvic rotation is the symmetry of the obturator foramen. If you look closely here, they are completely asymmetric. The right obturator foramen appears slightly more open and rounded, whereas the left obturator foramen is visibly narrower and more foreshortened. Additionally, if we evaluate the ala, the right iliac wing slightly appears wider and more elongated than the left iliac wing. In the radiographic positioning, that side is elongated and shows an open obturator foramen. It's the side that is closest to the image receptor. Therefore, these specific anatomic relationships conclusively tell us that the patient is slightly rotated toward their right side, placing them in a slight RPO, or right posterior oblique position. Next, we must critically evaluate the extremity flexion of the leg positioning, and this is where a major positioning error has occurred. For a truly optimal AP pelvis radiograph, the technologist must ensure that the patient's legs are internally rotated 15 to 20 degrees. This specific maneuver overcomes the natural anteversion of the femoral necks, placing them in a perfectly parallel degree to the image receptor to prevent foreshortening. This benchmark for confirming this correct internal rotation is the visibility of the lesser trocancers. When done correctly, the greater trocancers should be in profile laterally, and a maximum of only 1/3 of the lesser trocancers should be visible medially. In this image, we clearly have an improper internal rotation of the femurs. If you look at the medial border of the proximal femurs here, you can see that significantly more than 1/3 of the lesser trochanter is sticking out. They are prominently seen and visualized, meaning that the technologist failed to sufficiently internally rotate the patient's lower limbs, leaving the femoral necks partially foreshortened. Finally, let's address the technical factors and the overall image quality, which requires some serious critique. To be completely candid, the quality of this image is severely degraded and leaves massive amount of room for improvement. While the contrast scales allows us to differentiate the bones and the trabecular patterns of the cortical margins across most of the image, the exposure factors are simply not optimal. Specifically, if we look toward the midline, there is slight but noticeable saturation or overexposure right here around the sacrum and the symphysis pubis area. This localized saturation negatively impacts our contrast resolution and completely obscures the optimal bone detail in the central region. It indicates that the KVP and the mass relationship was not perfectly balanced for the varying tissue density of this specific patient, leading to data drop in the digital receptor where the beam was at least attenuated. To conclude this evaluation, between the severe image degradation, the slight right rotation, the improper internal leg rotation, and the absolute lack of physical lead markers, this radiograph falls significantly short of clinical standards. While it might be technically diagnosable in an emergency, correcting these fundamental errors is necessary for an optimal, legally sound image. Thank you for your time and watching my module evaluation.